Welcome to the Behavior Speak podcast. Now, here's your host, Ben Ryman.
All right, welcome to another episode of the Behavior Speak podcast. Today, we're back in British Columbia, Canada, where I have been doing a lot of my interviews, and I have the great honor of chatting with Dr. Amy Tanner. Thanks for being on the show today, Amy.
Thanks so much for having me. Very excited to be here.
Super cool, super cool. Amy has done a lot of things, which she'll be talking about soon enough, and she did her Ph.D. over in Ireland at Queen's University and wrote an amazing paper called Maximizing the Potential for Infants at Risk for Autism Spectrum Disorder Through a Parent-Mediated Verbal Behavior Intervention. And so we're going to be diving into that article a bit soon. That's published in the European Journal of Behavior Analysis. We'll have the link to that in the show notes. But we're also, what really kind of drew me to Amy, in addition to just we're on the BCBA-D board together and we've got those connections, but was when I kind of happened upon her website, and she described herself as a pediatric behavior analyst, which I had never heard of before as a term. And it sort of seemed almost unreal to me, because everything that I know about autism, and which isn't a lot, to be honest, particularly when it comes to the younger folks, is around in terms of early intervention, seems like folks are getting that kind of teaching not until they're age like 2 or 3. And so the idea that there's actually stuff out there available for folks before that, and that before they're diagnosed, is just, well, it's all really confusing to me. So I thought, what better to do than bring Amy on and have her explain it all. So, but before we kind of get there, maybe Amy, you could just kind of give us a little bit of your origin story, kind of how you got into the field and kind of what led you to Ireland and eventually to sort of working with the super youngins.
Yeah, that sounds great. Yeah, so I'm going to go back about 20 years in my journey, where I started my undergrad in psychology. I just loved learning all about brain development, how the mind works. I had no idea what I was going to do with an undergrad in psychology, but I was just fascinated by it. So I started at the University of Waterloo and completed my undergrad, loved all my psychology classes, and took, a really wide breadth of all sorts of different ones. And then I thought business was my calling. And so I had plans on pursuing kind of an MBA after that. But I had followed a boyfriend to Calgary from Waterloo and got started in the summer of 2003 with a very small company at the time called Lululemon, where there was only 3 stores. And so instead of pursuing my MBA, I, we were talked to about how, like, the growth of where Lululemon was going. And so I kind of caught that wave at the right time and kind of deferred my MBA and decided to stick with the company. So from 2003 to 2008, I helped grow Lululemon from 3 stores to 110 stores. And we went, public, and through different roles working with them, I moved to Miami at the age of 24 and opened all their Florida stores and got some really amazing kind of business experience with, such a rapidly growing company. But after 5 years and it going, from a mom and pop fun, little entrepreneurial venture to now, this, mega corporation, I started to feel like I just work in retail and I just work, in a mall in the US. And it wasn't kind of fulfilling, that novelty had worn off a little bit. So I had no idea what I was going to do. And it was right, timed with that, like the financial crash and everything, changing. Came back to Vancouver and, was looking at jobs all across the board, and came across a job about working with a child with autism and in this, thing called ABA therapy. And I, watched a YouTube video on it. I was like, that looks cool. And I always loved the idea of working with children. I actually thought, I'd love to be a pediatrician, but I never kind of took the right courses to get into med school. And so I loved, the idea of working with kids. I went and interviewed, it was under Sarah White and Courtney Phillips for my first job. And I loved it. And so I got hired with this one family. It was only about 10 hours a week, but I went home that night and into Craigslist at the time is where we were finding jobs, typed like autism or ABA, and literally like 90 jobs came up within the last 2 weeks that were posted. Like everyone was looking for BIs. And I was like, wow, there's so much need in this field. So I started to work under any consultant that I could. So I was working about 40 or 50 hours a week doing ABA under about 4 or 5 different consultants. And I could see right away that there were, everyone was doing things slightly different. There were things I really liked that some were doing. There were things, I wouldn't do in my own practice that others were doing. And so I really wanted to have a bit more say with designing the programming and curriculum. And sports was always a huge passion of mine. And I saw definitely a lack of, teaching kids sports and using sports and using movement kind of in the programming. And so that was something that I wanted to kind of do more of. So I started my master's virtually through Florida Institute of Technology. Loved that program. And then as I was kind of doing my master's full time and, working with kids full time and a bit on the verge of burnout, I saw a position come up in the south of France to go work with a boy with autism and live on their vineyard in Provence for a year and get supervision. And so it was like 25 hours a week. And so I could continue my BCBA supervision and, have a change of scene. So I moved to the south of France for a year and continued my coursework, continued that. And then wasn't ready to come home, ready for a change. So from France, I moved to Egypt and lived in Cairo, Egypt for a year, also getting amazing supervision from a BCBA out of Bahrain and one in New York. And had an incredible, interesting experience in Egypt. It was great after the revolution, but working with kids with autism there. And then I, was just about to finish my master's, came home, ended up at Monarch House, which was one of, the largest autism clinics in Canada, one of the bigger ones in North America. And so after having both business experience with Lulu and now clinical experience, I kind of was promoted into like a clinical supervisor manager position pretty quickly there. So kind of oversaw that clinic for about 4 years. And then left maybe just over 4 years ago to pursue private practice again. And during that time, about 6 years ago now, I started my Ph.D. and I started that remotely out of Belfast, of Queen's University there. And so, as you mentioned, I worked with kind of infants and toddlers showing signs of autism and how to intervene at the first signs through parent-mediated intervention. And then, throughout, since being back from Egypt, like I always had passions to travel. And so I've been lucky to kind of combine research and traveling. And I've been fortunate enough to present research in Sweden and Italy and France, Germany, the UK, Japan. And then I was invited as a keynote last year in Greece for their national conference right before the pandemic. So cool. I love to travel, I love research, and love working with the littles. Yeah, so that's a lot about me.
So that's super cool. So you've been everywhere, yeah. So south of France, were you supervised by someone from France, or was that a?
Actually, locally, Sharon Baxter, who was one of my supervisors before leaving for France, because in France at the time, I think there was only one BCBA.
Yeah.
And because this would have been 2010 or 2011, and so Sharon and we developed a Skype model for supervision, and so we're fairly early on the telehealth and working through that. And this family in France, they were also working with a clinic in New York. So every kind of 4 or 5 months, we would travel to New York and work out of a clinic there and receive more training. And it just happened one time, Sharon happened to be in New York while we were in New York. So she got to actually meet kind of the family and the boy in person too. So but so no, it was mostly through telehealth, and then a New York clinic for SLP OT, and then they were doing a ton of also alternative treatments out of there as well.
That's really neat. And then Egypt, that's amazing. So what made you choose Belfast? I mean, there's lots of programs in Canada.
Yeah, so it happened. I was at the conference in Stockholm, Sweden, and this would have been maybe 2014. And it was just walking around during the poster session, and my 2 future supervisors, who I didn't know at the time, Dr. Carola Dillenberger and Dr. Katerina Dunavi, they were there promoting their master's program. Wrapped up my master's, and I said, "What about a PhD?" And they said they just took on their very first remote PhD student, but they would be open to another one. And so I think it was their second ever. Now it's a full on, most people are doing their PhDs kind of virtually. Anyway, so it just, it turned into a great conversation. We had very similar research interests. So it was right after that Sally Rogers had just put out a paper on her pilot project, Infant Start. And both Corolla and I were super fascinated with the idea of working with infants and working with parent coaching. There was just something so like some synchronicity with, meeting with them and having research interests and then being able to do it remotely while working, but doing my research out of Vancouver. So yeah, it just kind of happened that way.
Fantastic. So maybe we could touch on this whole pediatric thing. So what do you mean by pediatric behavior analysis? What's the difference between that and just sort of what everyone else is doing with kids?
Yeah, what we're doing is we're starting very, very early and at the first signs of ASD. And so when you're looking at research that's been around at least a decade now, which more solid, but they've been looking at early signs and how early they arise, the last 20, 30 years. They're seeing a lot of signs start to emerge around 6 months of age. And by 9 to 12 months, a lot more reliable symptoms. By 18 months, it can actually be fairly reliably diagnosed. Yet the age of diagnosis still remains between 4 or 5 in Canada, 4 or 5 in the US, and older across different countries. And so there's such a gap between when we're seeing the symptoms and when the child's getting intervention. And a lot of that has to do with just bottlenecks to diagnosis. It's not that we don't see the symptoms there. It's just, it's going to then take, a while to get referred. It's going to be a wait list to get that diagnosis. And then there's going to be a delay getting a team start up. And so that's usually what will happen between the ages of 2 and 4. And so what we're doing is by looking at, as soon as there are concerns, there's no need to, wait for a confirmed diagnosis. So as behavior analysts, we're trained to address the symptoms, not the diagnosis, right? So we're looking at the behaviors. We're looking at what are they currently doing? What should they be doing? What's the gap in between? And then how are we going to teach there, regardless of, what the diagnosis is and waiting for, a confirmed diagnosis. And so pediatrics is something of just kind of highlighting that super early approach in that we're not waiting, pediatric would still, fall 3, 4, 5, but just to highlight that it's even earlier that we're starting with.
Okay. So there's one piece there around sort of the 4 or 5 thing. And so that's just a wait list thing. That's just folks not being able to access a diagnosis. So they're just not getting services. Is that pretty much what that is? That's
a big part. So there's actually a lot that goes into what's happening between, parents having concerns at 12 months and bringing their child in. So the first bottleneck that's happening is a lot of pediatricians aren't trained first on what the earliest signs are, as well as that there's anything that can be done, pre-diagnosis.
Yes.
So what happens so often is the first information that the parent gets is that children develop at their own rate, like just wait and see. Why don't you come back at 18 months or at 2 years and then we'll check again.
Yeah.
And so now they're waiting, 6 months or a year with given kind of no tools in between, right? So it's just like wait and see how they develop, if they're going to continue along that trajectory. What's happening in the brain at that time? So from 0 to 2, it's literally the most transformative time in your brain in all, from birth to the end of your life. Those first 2 years, your brain's developing more rapidly than any other time. So your brain's actually making about 700 neural connections a second during that time. And so that time, it's really like creating all the road work, what we call like neural circuitry in your brain. And so before, habits get too ingrained and before behaviors get too ingrained, they're really just emerging then. And so if you're working with, if you start to see signs or seeing red flags of something and they're not addressed during that time, really the circuitry is just going to be building stronger around those red flags and making them more difficult to undo later compared to as soon as you see them starting to kind of rework that neural circuitry to kind of maximize more, so they're more prepared for learning in a different way and interacting with their environment and participating in their environment, because that's where all the neural connections are made. It's made through that active participation in your environment. So exploring all the toys. So if you're really fixated on one toy, and that's where kind of the majority of your time spent, you're missing out on building connections in all those, like playing with all those other toys, or you're missing out on building those connections, interacting with people. And so those are those connections that we really want to make early on while the brain's really forming. So I think of it like if you were a city planner, you had the option of coming into a major city after all the major highways are laid and all the road work and all the buildings are there, and then trying to plan and rework some roads, or to go in just as, all the building materials are arriving and getting to be part of the planning right from kind of the ground up, right? And so the more circuitry that's made, it's just going to require, more resources and more time to make any changes there.
Wow, huge difference. And so, and I really need to get caught up on my, developmental psych stuff. But what I remember from old days of first year psych was this idea of this kind of critical period of kind of 0 to 7. You got to learn everything by 7, and then come 7, your skull hardens and your brain doesn't want to develop anymore, or something to that effect. That was sort of the message that was given. And so that's sort of why early intervention focuses on kind of, the 2 to 6 age, because that's the time, when all this is going to happen. But what you're saying is really that critical point is 0 to 2.
Yeah. So New England Center did a great study that emphasizes this. It was by McDonald and colleagues, I believe 2014. And so they looked at what are the differences between the onset of intervention months-wise, like how much does a month actually matter? And so during my talks, I always talk about every month matters at that time. And what they found is of kids that started intervention before 2 years of age, in the first year of treatment, 90% of that group made what was considered to be significant gains. So meaning that their brains were so moldable, they acquired information and knowledge so quickly. Between 2 and 2.5, that already dropped to 70%. So only 70% of the cohort made significant gains. Between 2.5 and 3, it dropped to 30%.
Oh my gosh.
And so they had a high bar of what was considered significant gain. So even, after 2.5, there was still lots of progress to be made, but there is such a drastic difference between starting after 3 and starting before 2.
Yeah.
And I see that with the work I do. So when I do work with parents, I meet with them weekly and I give them a task to do each week. Like we kind of work through different goals and sequential targets. And what they're able to accomplish in 1 week with a child, that's say, 14 months old, might take, 2 months in early intervention when that child's, 4 or 5.
Wow.
And so you just see how quickly you're able to kind of help with those early acquisition skills when you're getting in that early.
Crazy. It makes you think of sort of these. So again, I don't work in early intervention, so I'm just speaking from as a spectator, but it makes you think of these early learners, I guess, as they call them, these folks that, don't have language and, have a lot more, lack a lot more of the functional skills and whatnot. And, you'll see them. I did a year stint before I kind of got into my master's in a early intervention center, because the professor told me you have to work in early intervention if you want to be in a BCBA. And I said, all right, I'll do it for a year, and that's all I did it for. But and I was back to adults. But I would watch sort of these early learners, as they called them, really not get a whole lot out of it, and actually would see them later as a consultant serving adolescents. I'd see them later as adolescents, and they were the same, essentially. And so it sounds like if maybe some of these folks got in the 0 to 2 range, they could have had a lot more gains.
I think so. I definitely agree with that, but I always want to come from a place of hope for parents, and that we don't want, you don't want
Yes.
someone that started intervention at 4 to carry around this guilt of like, what have life been like? So when I
Mm,
see like kind of the early learners that you're speaking about, so much too, what I look at is what type of programming were they given during
mm-hmm.
those years. And I always recommend everyone that works in early intervention to work with adults and work with teens at some point so they can see the big picture and really see like, okay, given the opportunity, with this adult or with this teen, what would I have taught them at 3, 4, and 5 that
Yep.
was missing from their program? And so I think, our field's constantly hopefully doing better. But when I look
Mm-hmm.
at what was very common before is seeing, 8-year-olds and 9-year-olds still working on VB map goals of matching flashcards and, inset puzzles or things that will have no relevance to their quality of life. And so I really look at, looking at functional programming and how
Yep.
did we miss the boat on that because we were, just following curriculum. So I think it's both. I think, definitely the earlier the better, and that's always my message. That's what really aligns with the research. But then also very strategic and efficient programming, and like, let's not waste time teaching skills that aren't improving anyone's quality of life.
If you're planning on collecting continuing education credits for this episode, you'll need to go to www.cbiconsultants.com and enter the 3 secret words. The first secret word is lemon. Okay, so the other sort of barrier that I'm seeing here is at least, and I don't know, I'm sure it's different in different countries and certainly even different provinces, but in our province, we have this kind of funding model that gives folks, a bunch of money, from diagnosis until they turn 6. And it's $22,000 or something like that a year, which, is sort of based on some of the studies around, some of these sort of LOVAS kind of base studies and what those require and so on and so forth. But folks aren't going to get that official diagnosis till 4, potentially. Some might get it earlier, I guess, if they go private and pay for that out of pocket. And for sort of 2 parts to this question. One, were you saying that it is actually possible if they got in early enough to get an official diagnosis at 18 months now? Is that the case?
Yeah, but in BC, that's definitely, they're diagnosing as early as 18 months. And the diagnosis at 18 months, when they go to re-diagnose, at 2, 2.5, 3, they are stable, right? So they're finding they are reliable by that age. Earlier than that, they don't have the same stability. So if we were trying to diagnose at 12 months,
Right.
and then we go to check, at 2 years, there's less stability with that diagnosis,
Gotcha.
but by 8,
maybe only half.
by 18 months, we're pretty sure if the signs are there, then they're going to be pervasive enough and persistent to maintain throughout.
Sure. So say you're a family that's lucky enough to get a diagnosis that early, then great. You're definitely gonna see. Well, first off, you're gonna see that money for
Longer,
maybe a couple more years than other folks because there's no retroactive money coming your way. But and then they're actually in the 0 to 2 range, so they're actually maybe potentially actually getting a bit more, growth there. But for all these folks that,
waiting or
that are waiting or that are younger than 18 months and the signs are pointing there, they're not getting any funding for services. So it seems odd that I guess this is where the courts have to come in. But so the best time to intervene is 0 to 2, but we can't, because we can't give them an official diagnosis. We can't give them any money. And it just seems like a bit of a paradox.
Well, so I've got lots to say on this. So much of our medical system is retroactive and not preventative to begin with. And we know if we invented in so many different things preventatively, we would save so much money retroactively. But that's just, the nature of the beast. And, whoever makes government policy is usually so removed from frontline research, right? And there's such a disconnect of what is best practice compared to, what can the government actually do.
Mm-hmm.
But another thing that's really important to keep in mind is so much of the early intervention research was done with children 3 and up. So what we consider best practice of, using a BI and, having the intensive, whether that's 15 or 20 hours. I don't really agree with anything, more than 20 hours. But, I try to stay, much lower than that. But even that, the research around that is done with 3 and up. And when we're looking at kids that are 18 months, what's really starting to happen now is we have to discover what is actually best practice for that age group, because what's best practice for 3 is not what's best practice for 18 months. And so for a 1-year-old, it's not natural or normal or best practice for them to be spending 20 hours a week with a therapist, right? The learning comes throughout all their daily routines at home. So it comes through diaper changes, it comes through mealtime, it comes through bath time, it comes through getting ready for bed. And so the best people to be doing the intervention is parents, because they're with them through all these learning opportunities all day long. And they're also ones that they're going to be really easily shaped by their child's behavior, regardless of, whatever their child's doing. So we respond to kids so quickly. So I always think when, if you were holding a 6-month-old baby and you go to make a funny face and the baby laughs, you're going to do that face again.
Mm-hmm.
If you do the funny face and the baby looks scared and starts to cry, you're not going to do that face again, right? So in 1 second, the baby's changed what you're going to do. And so from a parent's point of view, say every time you bring out a book, your child either tries to rip the pages or throws it or runs away. Over time, you're going to stop bringing out books. If every time you sing, there's no response, like it's if nothing's even happening, the parent's not getting that reinforcement and that shared interest. And so they're going to sing less. They're getting less eye contact. And so what happens with months and months of this is the parent's behavior starts to shape in the way that they're going to be vocalizing less. They're going to be giving less eye contact. They're going to be presenting less learning opportunities because they haven't been reinforced. So it's definitely unconscious and it's happening, small incremental each day. And so this just creates kind of this negative transactional cycle, right? The child's developing atypically, and so the parent starts to respond atypically.
Mm-hmm.
So the best place to begin undoing this is working with the parent and parent-mediated intervention. And so how that fits into funding is with just doing an hour a week with the parent and giving them one focus for the week. And when we can break it down first, where I use behavior skills training. So we're going to first give the instruction and the rationale on why we're teaching this. Then I'm going to model it. The parent's going to practice it and rehearse it. We're going to give feedback. We're going to set up a goal for the week. Now, the parent has the opportunity to practice that goal in so many different ways. So they can practice it at bath time and mealtime. And so the skill becomes generalized. But so with 1 hour a week, we're able to have a lot more impact because the parent's essentially doing it, 5-10 hours a day during the child's waking hours. So it's a much more affordable for the parents that are paying out of pocket. Like it is out of pocket because there isn't anything to cover it, but it's an hour of our time per week versus, trying to pay 20 hours of therapy out of pocket.
Right.
So that definitely helps. But one of the things that I also want to do is, and hopefully by the time this podcast is live, is have a lot of these lessons on video so that both parents and practitioners have something to go to of like, what do we teach? How do we teach? And at least have some resources available that way so that if there isn't a BCBA nearby that does have, very early intervention training, or if you don't have, the finances, at least there's kind of something and some resources rather than nothing.
Okay, cool. So essentially, they don't need $22,000 a year.
Yeah, no.
when they're at that age. And maybe we might even, if we could start to show, the value of this.
Yeah.
Maybe there could be a little bit of funding because it's not that much.
Absolutely. And when you look at like what a lifetime of services costs, both in lost wages and in, intensive services, say for an early learner, it's about $1.5 to $2 million per person over a lifespan. And so if, a 12-week course of this type of intervention, it would cost, about $1,800. And ultimately, regardless, it's going to lighten future services later. It's going to do that different degrees by, each person, but it will have an impact of lightening that. And so when you look at, the cost benefit analysis of just being able to provide, preventative services, even just for, any child that's showing different red flags. And their screeners have gotten quite good now that they know that once there's a certain amount of red flags, and I can talk about different screeners later of like what's out there and what's reliable. No, by 9 months and 12 months, when there's a certain amount of red flags there, the likelihood that that's going to result in an ASD diagnosis by 18 months or 2 years is quite high. And so when we have those, the screeners showing, high concern, intervening with those children, I think overall, there's going to be such a cost benefit analysis because they're going to need less services later. It's not about, not getting the diagnosis at all. It's just about kind of how do we maximize their trajectory and maximize, their ability to learn and acquire skills as their peers do.
And so, and I definitely want to talk about those screeners, but if those folks have been now screened and kind of looks pretty good at, 9 or 12 months, does that give them enough sort of information or ammo or whatever to start on the road to a diagnosis so that come 6 months from now, maybe they could get one at 18 months and maybe the wait list shortens for them, or are they still not going to get a diagnosis until they're 4 because of what's happening sort of on average?
It depends totally where they are and probably the doctor that they see. So I find, we're very lucky in BC for, like I always tell parents, if you have concerns, go to a pediatrician that actually diagnoses autism, because they're going to be the best one to tell you, yes, there's enough symptoms here, or no, there's not. So if your pediatrician, if their practice doesn't entail the diagnostic point, they're not in a great position to tell you whether there's signs or not. And because what we've seen time and time and time again is parents having concerns and it being dismissed by their pediatrician. And so getting to a developmental pediatrician that is actively involved with diagnosing, whether that's through Sunny Hill here or any of the private diagnosis, they're in the best place to tell you, if there are concerns. And then something else to keep in mind as well is that if the symptoms are there kind of by 12, usually when parents are seeing them at 12 months, chances are they're more severe symptoms and they're kind of on a more severe trajectory rather than if their symptoms are a bit lighter, right? And so, or more mild. So that's all the more reason to, get help sooner. So they know this. Pediatricians know the importance of using these screeners. So there's a really popular one called the MCHAT. And so the CDC out of the US knew that these screeners are, essential for getting kids diagnosed early and starting intervention early. And so they mandated that in the US, they need to use these screeners at every child well visit at 18 months, 20 months, and 24 months. And so they put those in, but what they actually found was that of 75% of the ones that positively screened, like showing that there are red flags, they failed to identify them. And the reason why was that doctors were now giving these screeners, but they either weren't scoring them, or the score would come back in the concern range, and then the doctor would use their clinical judgment and say, it says concern, but I wouldn't worry about it. Let's just, come back in 6 months. And so, screeners are only, as all diagnostic tools, as good as, actually scoring them and, following the protocols. And so if we're using clinical judgment to, kind of reduce the screener, then that's not helping either. And so that's kind of what continues to happen. And so I'm sure many clinicians listening to this will have heard that from many families about how early they did feel something was up and how many times they were dismissed before someone actually believed them and got them kind of on the right track.
So I guess then it's going to be partly on the families to kind of advocate post-screening.
Absolutely, yeah.
Because no one else is going to,
Yeah. The screener definitely. So there's a few screeners that you can do online. So the MChat is one, and then there's the infant toddler checklist is one, and the SORF is one. And so parents can do these online. And so you can print off your results. It scores it online. And so taking that, yes, to your doctor's visit can definitely help support. Because in a doctor's visit, right, like they're going to have probably like 15 minutes with the doctor, right? And so it's such a small snapshot of what's really happening. But, parents are with their child 24 hours a day and, see a lot more than what a doctor can see. So that will definitely help. But, if you have concerns, you're definitely the expert on your child. And so, yeah, if you feel that you're dismissed, get a second and third opinion. And I've heard from a few moms, it took, 4 doctors before they got the right one that did refer them for a diagnosis. And sure enough, they got the diagnosis, but, that's a lot of time in between and effort. And a lot of people probably, they have concerns and they go to the doctor and the doctor says, don't worry. And that's really what you want to hear, right? You want to think that you're overreacting, and you want to think that, okay, I'm just, a bit of a hypochondriac. It's my first child or whatever. I just got to relax. And so a lot of people probably don't go after, one or, go for a second opinion because it's, it's news that they want to hear as well.
So that's interesting. So you don't have to get those screeners from the doctor. They can just kind of go online and and do them themselves. And what's the SORF? What's that stand for? Do you know?
SORF of
screening, probably.
Find exactly.
Maybe.
So it's by Amy Weatherby, who's a phenomenal researcher, and she's got this website called the Autism Navigator.
Okay.
So she created this tool. She created the infant toddler checklist, and she has all these other amazing resources. So she's created like 16 by 16, so 16 gestures by 16 months. So so from 9 months to 16 months, your child should be acquiring at least 2 new gestures every month. And she's got what those gestures are. She has what are 16 early signs of autism by 16 months. So so it's just learnercommunity.com. But I'll figure out what the SORF.
No, that's okay. I can find that later. And so would you suggest to folks that it's maybe a good idea to do all 3 of those and bring those to your doctor, or do you just need to do one, or are they different?
Yeah, they all kind of have been tested on different ranges. So the SORF is systematic observation of red flags.
Okay. Makes sense. Yeah.
And so the infant toddler checklist and the SORF are both developed for earlier, where the MChat's actually just been tested on 16 months and older. Although it has been kind of verified in a few studies of using it 12 months and 13 months, I still think there's a lot on there at 12 months that if there are concerns, because the flags that are on there usually are intact much earlier, kind of about 4, 5, 6 months. Kind of, does your child attend to their name? If you point at something, does your child follow your point? Does your child point at an item? So a lot of those things develop, 10 months, 11 months. So the MChat can still be good for those, even though it has actually only been verified 16 months and older. But the SORF and the infant toddler checklist, both, I think, even as early as 9 months, 9 to 24 months.
Wow.
So it's a good place to start. And then I've also done training on the AOC, which is the Autism Observation Infant Scale. And so that's from 6 months to 18 months, I want to say. But that is a clinician-led assessment. So it's similar to the ADOS, where it's kind of structured and led by the clinician. But it has been, tested as early as 6 months, more reliable between 9 and 12 months.
And is it only going to be those pediatricians that diagnose autism that would also do these screeners?
Likely, yeah. But there's definitely lots of resources online of the checklist ones. So both the SORF and infant toddler checklist, you can do with it. It's just a kind of a forced choice or Likert scale of how much your child's doing it, and it scores it, and then puts it into either no concern, some concern, or like high risk.
I guess the better question is would those pediatricians that don't diagnose autism, see any value in those if you brought them in, you know?
I would hope so,
Yeah.
but hard to say, and might vary as well.
The second secret word is infant. And how to sort of, and these may be sort of philosophical, rhetoric questions, but how do you kind of go about educating pediatricians, you know, to...
Well, one thing is they might kind of believe your concerns, but if, say, your child's 12 months and they know 18 months will be the earliest that they get diagnosed, a lot of them don't know that there's anything to do right now between the 12 and 18 months, as well as a lot don't realize the time sensitivity of intervention, right? We have this general thing, before 3 is great, it's early intervention. But because, you know, research is done in such silos that, you know, and pediatricians have to be experts on, or have such a broad range of of their knowledge, that they might not know, you know, like that New England study that I mentioned, the difference between starting intervention before 2 and starting after 3, how it goes from, you know, 90% to 30% of significant outcomes, right? And so they might not realize the time sensitivity or what to recommend, right? So that could be one of the barriers of just like, yeah, I see your concerns. You know, the best I can say is come back in 6 months. And then if they're still there, we can, you know, make a referral. A lot will still like want to see them again at 2 before, you know, making the referral. And so, you know, that even postpones it longer. Oftentimes too, the first referral that they'll make is for a hearing test. And then, you know, if speech still hasn't developed, then they'll refer for SLP services. Then it's often the SLP that's letting the parents know that they should be pursuing kind of a diagnosis in an ASD, or that they see red flags there.
Wow. Okay. So obviously, you know, if you're going for, you know, one of these screeners, then you've got some idea in your head that you need a screener, and that you need to find a pediatrician that's interested in autism and whatnot. But how, as a parent, do you even know to do that?
Yeah. What are those early signs, or the...
Yeah.
So what parents report, there's different things that clinicians see first and that are seen in the studies versus what parents most commonly report. So what parents most commonly report is the child doesn't respond to their name and doesn't respond to the voice as much. So that's usually one of the things that tips them off. Infrequent eye contact and infrequent looking at people, as they'll often see that. So hard to get your baby to look at you. Less affect, so more difficult to get your baby to laugh, especially like with you, like so that shared enjoyment. Limited use of gestures such as show and point. So there's so much that develops in communication before expressive language. So some parents, they're not tipped off until kind of 18 months into, where their child should have, you know, 10 words, 20 words, you know, by 2 when their child's not talking, they're like, okay, something's up. But there's actually so much language that comes between using gestures, responding to gestures, babbling, which babbling sounds should they be having, using to and fro babbling. So imitating, you know, where the mom says baba and then the baby says baba, and then that back and forth of imitating babbling that way. And then using kind of directive babbling when you want. So they, you know, point to something and say, you know, ba, 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 ba. So that's very, you know, a good precursor of communication, as they're using very directive babbling, often paired with gestures. And so not seeing kind of those precursor communication, less imitation. So babies, it's early, even before 6 months, but at 6 months, you start to even see imitation more readily develop. And so that could be sticking your tongue out, or smacking your lips, or just showing them something with an object. So picking up a maraca and shaking it, and then putting it down and seeing the baby pick it up and shake it. You know, that would be showing imitation, right? And so imitation's often delayed. What clinicians find, so in clinical research, the earliest indicators that they're finding are actually motor skills. So there's a head-leg study. So when the baby's lying down on their back and you hold their hands and you pull them to sit. So at 6 months, kind of, if their head's really lagging back, that's kind of motor milestone that they're not quite meeting. And then there's a few other with kind of grasping and reaching when they're really looking at what are the earliest things. But those aren't the things that the parents are necessarily picking up on, or the motor skills. It's just more what they see kind of in the clinic. But other things, more interested in objects and people. So that's, they're 8, 9, 10 months. And then there was a great study done by Ozenhoff in 2018, I think, Sally Ozenhoff. But we used to think regression was fairly rare. So we thought of autism having 3 different phenotypes, in that kind of regularly develop, and then at 12 months, like a plateau where the skills kind of stop, regularly developed kind of 12 or 18 months, and then show a regression and kind of fall back, or having, the symptoms not on a regular development pattern from about 6 months on. But what Sally's study saw is that we just aren't tracking regression correctly. And that regression was actually so much more common when we changed the way that we tracked it. So when we looked at regression before, what we normally did was ask parents, has your child lost any skills, or have they regressed on anything? And so what they're doing there is they're actually then having to retroactively go back and assess. And then they're also having to do categorically, kind of yes or no. And so when we're using retroactive and categorically, only about 29% of parents, and not even many more clinicians, would say that regression has occurred. When it was done in the present, what's the word I'm looking for there? So at each visit, so say every 6 weeks or 3 months, where they measured how much is that child smiling, how much are they looking at adults, how much are they responding to gestures, and some different social communication targets. And then they looked at 3 months from then, and then they looked at 3 months from then, and they rated it out of 5, from 1 to 5. What they saw is that 88% of kids actually regressed in social communication skills. But because, they only were able to see it when they compared the exact same target to something 3 months from there. And when they had more of a sliding, like a scale of 1 to 5 rather than yes and no. So by moving regression to in the present and using a dimensional scale rather than retroactive and categorically, they saw regression far more common. And so what I imagine we're going to see very soon, they're probably in development now, is screeners that are looking a bit more at measuring those same skills at intervals, like each month, and then comparing the score to what was it last month, what was it 2 months ago, to see if we're losing skills. Because regression is very tied with ASD, that it doesn't happen in a lot of other, say, developmental disorders. Just, one of those other kind of early signs. The repetitive, so any kind of the stimming or stereotypies, oftentimes they're not really reported till 18 months. Sometimes they're seen earlier, but those tend not to be one of the first things that parents notice. And then temperament, so either hypo or hyper reactive to different things. So some parents will report their baby was so easy, they never got upset. They could put them in the backseat of the car and drive for 6 hours and they didn't hear a peep. So that would be very hypo-responsive or hypo-reactive. And then the hyper-reactive of just, the smallest change. And it could be sensory, it could be they don't like the shirt or the food or something, but having very, very big reactions to sounds and sights or textures. So those are some of the early signs. But with early signs, and I always kind of mention this in the talk, is so much of the early signs, they're what we call like the deficits of behavior. So when we think of all behavior, either comes in excess or deficit, like is it something additional we're seeing, or is it something that we're just seeing less of? So many of the symptoms actually are just less of something. And so they're so much harder to just see kind of with the naked eye day to day. Like if a child looks at objects, like say a typical developing child looks at objects 40% of the time, and people 60% of the time. And then a neurodivergent child maybe only looks at people, 40% of the time. It's going to be so difficult to see the difference between 60% and 40%. And so that's where the screeners really help, because it's really looking at like the cumulative aspect of all these symptoms together. Because just eye contact on its own or not responding to name on its own none of those are, of concern. It's really when you're seeing a big enough cluster of the red flags that it starts to be of concern. And because the stereotypy, which would be considered those excesses of behavior, they're unlikely to be reported until kind of 14, 16 months. So those are the ones that are easier to see with the naked eye because they're something added that, typical development you wouldn't see. But so many of the other ones are just deficits, and it's just that the child's doing it less, not that they're doing it not at all. So they're babbling less, they're looking less. And so those can be difficult to see without a screener.
So, I mean, it sounds like, this is interesting. So it sounds like, which is good. So some of these measures are getting more sensitive and able to pick up more of this stuff. But as a new parent, like I don't have children either, so I don't have any kind of experience in this, but as a new parent, I don't know that I would think to even ask any of these questions. I mean, I think it might be more likely if I had a second child, and I'd be like, yeah, Jerry didn't do any of this, but Billy's doing a lot of this, and so maybe I should go get it checked out.
Yeah.
And so, if you have a baby, you're probably going to the pediatrician pretty regularly anyway, just as sort of. That's sort of a normal thing, I guess. Yes.
Yeah.
Okay. And so would you just presume that, is that sort of the job of pediatricians, is to check these developmental milestones and whatnot anyway, regardless of whether they're knowledgeable about autism or not, just to kind of watch for head tilts and watch for all that kind of stuff?
I feel like that's the assumption. And so that's what we're hopes happening, but I don't know that it's always happening. And if they're looking for, they're looking for something different. And so for your first child, I'm sure it's so hard to see those subtle signs because when you're probably exhausted, you don't have, you've got a sample of one of, what you're looking at for development. So the parents that are usually on it, at 9 months, it's because the symptoms are more severe. Like their child just won't look at them and they feel it during nursing. Like during nursing, people talk about how this is, a bonding experience and their child just watches their eyes and they just feel, their child's looking anywhere but their eyes. A lot of times they feel that their child might be deaf or hear because they're not tuning to their voice or they're not, recognizing any common words. But so the symptoms usually have to be fairly severe, more pervasive at 9 for I think a first time parent to see. But yeah, when it's your second child, a lot of times then it's a bit easier to just see they're not smiling as much or they're not hitting those milestones that their first child did. So that can be a bit easier. And that's why, the government in the US has mandated these screeners. It's sad that they're not actually being used as they need to be. But hopefully, just as everything becomes, people become more aware of pre-diagnostic intervention and how important kind of year 1 to year 2 is, that, it might be more top of mind for pediatricians, but it's definitely something kind of in my action plan of just disseminating that information to doctors. The CDC, I don't know really what's happening in Canada of how much they're on this, but if you go on to the CDC website and you look at autism symptoms for infants, they actually have some great courses that doctors can take on there where they have all these videos of seeing what does it look like in 6 months and 8 months. And so I was actually pretty impressed with, now I don't know how many people do that or how optional it is, but the resource is there. And so, yeah.
If folks are lucky enough to get the right pediatrician or get the screening done and we'll talk about this sort of after, but somehow they manage to find you and you're able to, you've kind of come up with a program of your own that was kind of a result of the study, I guess, right? So let's maybe dive in a bit to your study and kind of what that all looked like, who was in it and how you got to what you got to. The third secret word is Belfast.
Absolutely. So one thing that I'm super passionate about is when researchers are publishing, I always believe if you're reading a paper, you should be able to actually learn something from that and apply it to your practice, right? Like that we're able to actually use that information. And during my PhD, what I kept finding is that anyone that was publishing on this topic, what they were actually doing, their methods were actually, very vague in the paper. And, it was like a lot of intellectual property that they were protecting, and you couldn't access it unless you went to their clinic and either started to work for them or, underwent, a few years of intensive training and certifications. And so it just wasn't accessible. And when we look at the time sensitivity of this, like if you've got a child that you're concerned of, it's like you need information now. And with BCBA, like we're lucky in BC, we do have a good amount of BCBAs, but then same thing, if they need information on working with a younger client, the idea of signing up for a training that's happening 6 months from now and then getting, level 1 done and then having to do, a year of validation or whatever. And then, finally being able to put into practice, it's just not, it's not going to build capacity and it's not helping the kids right now. And so one of my main goals with my research was to be as transparent as possible and really be able to just put out there what it is that I'm doing. And it might not be the best thing, compared to what, Sally Rogers is doing or social ABCs, but at least it's something that people can follow and it gives some kind of framework. And so I came up with the Spark, which is a sequential parent curriculum. And so it's just 12 lessons on what kind of skills can we kind of teach natural environment. And so what I love doing is working with the parents, because when you start at the beginning, what you see is they're really trying, but they're spinning their wheels a bit. And you can see just kind of the stress in their face and their shoulder. They're really wanting to connect and wanting to play, but they're just finding they're not getting anything. They're not getting a ton back. And so after a few sessions, you just see, their shoulders relax and they're being able to connect with their child more and enjoy playing with them just by, a few different things about reframing. So we always start our first lesson. And I think this is similar to what Sally Rogers teaches. And it's also in the Early Start Denver model, but finding the smile. So let's find 5 new ways to make your child laugh. Because when your child's laughing, they're going to be more engaged and that's going to be the best time for them to be learning anything. So when we're happy, what happens is like dopamine floods into our brain, but it actually like turns on all the learning centers in our brain. And so it makes it the best time to actually be learning anything compared to, if we're stressed or just not enjoying it. So what that also teaches parents is really tuning into like their child's affect and where is your child having the most fun. And so it teaches parents how to do kind of preference assessments. Like, does this make you smile or does this make you smile? And really seeing like, what are the things that they enjoy? And then we go on from there about following your child's lead and your child's interests. So what I saw so often with parents is they're trying so hard, but their child might be, very like focused on playing with a car. And they're, 5 feet away with like a new toy, like, whoa, look at this. And like wanting their child to come to them rather than really looking at what's your child really interested in now, because that's where their attention is. And then how do I join their activity and make it more fun with me there than it was, without me there? So when we see our child playing with something, oftentimes what happens is we're like, okay, I'll go play with them there. But we end up actually creating so much more demand on their play that it's not fun to play with us. So we either, let's take turns. And now I'm taking their toy from them, or I'm changing the way they play and I'm disrupting the plan that they've had. And so they keep moving away from us, or play isn't becoming reinforcing, it's becoming punishing because we're changing it. And so teaching parents about like, how can I make their play more fun right now? And so a lot of that first starts with, let me go beside them and get a similar material and interact beside them with the same material, so that we can start to, I can show them new things to do with that without taking their item. And I can, so if they're, say just rolling a car back and forth right in front of their eyes, you take a car too, but now you can add some fun noises and maybe a block. So you push your car into a block tower and the tower falls down. Then you set it up. You do it again, you set it up and you see if your child wants to crash into it. So now you've added on, you've made their play more fun with you there. And you're being kind of that happy or the playful helper. And so often it's those two things just, they're just like such a small switch. And it makes all the difference with the child wanting to engage, right? And really looking at, where your child's happiest, and then building up that repertoire, right? So showing them more things that might make them happy, and make them laugh. And then how do we kind of expand on that and work on it together without kind of interrupting theirs and taking theirs. So that's kind of the starting. And so, sorry, that was a big tangent of this curriculum, but so whatever I've in the study that's published, I have a lot more detail in there of week to week. And so someone with training in verbal behavior and behavior analysis would likely be able to use that as a framework. But I've also created a manual that I will make available shortly on my website, maybe by the time that this is live. I did it as part of my doctoral studies, but I just wanted to maybe spruce it up a bit and add some pictures, but that would provide even more information for a BCBA to follow and to troubleshoot. And even if a parent didn't have access to a BCBA, I've tried to write it completely in parent-friendly language and away from jargon, so that they can follow it. The BCBA would hopefully put what theory and what we're working on behavior analytic terms, but I've written it all in parent-friendly language so that it's at least a tool that's available to everyone. It's out there, and that you don't have to, undergo separate training, and it gives you a starting point. And there's lots of other things. And I think Amy Weatherby, she's doing very similar stuff on her website. Like, so much of what she's put out is free, is open access. She's done really, really great things.
So this manual and these steps, is this made for a BCBA to take and work with a family, or is this just made for a family to take and start doing on their own?
Ideally, it would be supervised by a BCBA, because I feel they'll get more out of it. But I wanted to make it that, for people in a country that maybe they don't have access to a BCBA, or because there's no funding available for it, that if you didn't have the means to pay, a BCBA their hourly rate, that you would have a starting point, and that it's going to just cover a lot of the things. And I've put in examples of different ways that you can work on this target and troubleshooting. So if your child does this, what can you do? And if your child does this, what can you do? But it is recommended that if you have the option to work with a BCBA with it, that I think you'll get the most out of it with both the parent and the BCBA working from the manual together.
Then is this also going to be an open source thing, or?
Yeah, so my plan is to make the manual completely open source, and then have a video for each lesson that would be a very low cost, or maybe just a cost for professionals.
Sure.
Whether it's, $10 or $20 a week for those 12, so that it's available, but just, covers any of the cost of hosting those videos or creating them, but having it, just readily available so that people can get information quickly and not have to. Because there are definitely tons of clinics and people doing great research, but I found it was so frustrating when trying to learn what other people were doing, because it would say, this program, very effective, or, the child changed in these ways, or these targets were met. But then there was very little information given about, okay, what did you actually teach the child? How did you actually teach them? What order was it taught in? Who taught them? Was it a clinician? And so I've laid it out both in the manual as well as in the research about, if you are working with a BCBA, for them to do it in a behavior skills training way. So I really believe first explaining to the parent, what are we teaching today and why is that important? Like, I think the why is so important, right? You need to know, why do I need to do this? And then being able to model it with their child so that they can visually see what it would look like. And so one thing I always work with my students on, my BIs, when they're always like so excited to be consultants, is that you never stop working with the kids. You want to be working, modeling things, for your team all the time, so that you can jump in with any child and actually model what it should look like. Because if you can't do it with their child, it's not going to put a lot of kind of validity into what you're saying. Whereas if you can really show, like, this is, how you can do it, and then you can help also troubleshoot when it doesn't go the way that's planned. So then you'd model it, then you'd get them. What's so important is actually, and as awkward as it is saying, okay, now it's your turn. Let's see how it goes, because we can make things look incredibly easy because we have decades of experience working with little kids, and some things that we do, so naturally, we see their attention like weaning to something else, or we're just, sometimes a few steps ahead, or it can just be split second differences. So we can make things look very, very easy. And so if a parent's only watching and then after you leave, then trying, they can, not necessarily have the same success. And so it's really important, that rehearsal piece, and then providing feedback like, yeah, that was great. You can try it this way or this way. And then with each thing that I teach, rather than just teaching kind of the grandiose theory behind it, is let's teach it on 5 different play sets. So how would I, if I'm playing with cars and now we've crashed the car into the tower 20 times, how do I expand the activity of cars? So now I'm going to add a ramp, maybe I'll add bubbles, but I want to show them just with that activity. Then I'm going to show them with another activity how we're going to expand it, and then another activity, rather than just try to say, yeah, and then just expand it. Because what I think we always take for granted is we've got so much knowledge in developmental milestones, in lots of different creative options of what you can do to change that activity. We've got, information that we're getting from the child on where their interest is now, what they're going to like. And we kind of put all that information in a second, make a change to their play activity. And so that can be a lot for a parent to do, or to expect the same. And so without them actually being taught in an activity, like 5 different ways to expand it, and then in a different activity, 5 different ways to expand it. And then I find just the way that we would teach, our kids, we teach, maybe 3 to 5 examples of things and then check for generalization, right? Now you give parents a completely new activity, and can they think of different ways to generalize it or to expand it? So it's a lot of modeling and walking the parent through each step and providing that feedback, and really kind of working on that rapport with the parent so that you can give coaching and feedback, and that it's, that it's heard and applied, because that's really where the behavior change will happen.
So is the manual and the video enough for a BCBA, or would you provide some kind of mentorship training as well? Or
It's a great question. I'm always learning, and so I feel, if they're seeking out mentorship from anyone, I would go to, even people that have been doing this longer than me. So, but I don't know, how available they are, what certificates. Jessica Bryan out of Bloor View Kids Hospital in Toronto, she's phenomenal. Sally Rogers is phenomenal. Lonnie Zwagenbaum, Amy Weatherby. So those would be my first, if you've got any option to be mentored or do courses, they're very much the pioneers of this. But I have, I'm currently working with a BCBA that they were already working with a child on the spectrum, and then their young sibling, the parent has concerns with at 11 months. And so they're already more positioned well with the family. And so I'm kind of helping them go through providing some mentorship that way. So I always think, yes, mentorship and coaching, the more the better. But I've tried to design this in a way to build capacity as best as possible, in that you don't need me for it. If you've worked with 2-year-olds or 2.5-year-olds, going to 18 months isn't that big of a jump. It's really just looking at getting a bit more familiar with what are the developmental milestones. And then what I find the biggest challenge working with any kids less than 12 months is you can be fairly limited by motor skills, because they don't have the coordination or they don't have the release. And so under 12 months, you might need a bit more mentorship, because, it's just, there's just a bit bigger of a gap between 12 months and 18 months. But if you work with children 2.5, with this manual, 18 months or, 13 to 18 months should be okay. Cool.
So in your practice, do you just work with the youngins? So do you sort of discharge when they turn 3, or do you keep going?
No, I keep going. Sometimes parents won't really let you go and discharge. It's not always an option. But no, most of them I've seen through to kindergarten, grade 1. And then, what I do find is when I do start with them at 12 and 18 months, by kindergarten, they actually aren't needing hardly any services. The parents struggle to let you go, but it could be, checkups every little bit, or, really moving them to a junior model or some social skills groups, or,
Yeah.
but it's the kids that have gone through my program, I find by kindergarten, they're not needing those intensive services. But I do work with all early intervention, and I have worked with one adult, for about the last decade now. So I still have, a 27-year-old woman on my caseload as well, which is, I think, always, just always important for big picture with early intervention is keep in mind, what are we teaching and why? And, how does this help their life later?
Yeah. So the reason I ask is I'm wondering sort of, what does your approach look like kind of after they're done sort of the spark kind of thing, like, because this just seems like it seems like it's very child led, and it reminds me of and again, not an outsider looking in, but it reminds me of these NDBIs that folks
Absolutely,
are doing. And so is that kind of that approach that you take sort of from 2 and up?
Yeah, so exactly. So I would characterize it as an NDBI. And so even when I start with a child, say that's 2 and has just been diagnosed, I recommend, I insist that we do like the parent training at the same time, as well as starting up their team, because I feel these skills that we're training the parents, I've seen they just make such a difference when the parents are confident in these skills, rather than just moving to, a practitioner model right from the beginning.
Yeah.
And then even up till 2, I still recommend parents are kind of the primary ones leading. But once we hit 2 and they've got their funding and they've got their diagnosis, then I normally start to, depending on their needs, and we always make a model based on what the child's needs are. Sometimes parents always ask, like, what's my model? And it's, I always say it's going to depend on what I think your child needs the most. And so with kids that young, I always think quality over quantity, right? And so SLPs are so great with play for that age group. And so a lot of times we'll first start to fade to like a clinician only model. So say 4 hours a week, 1 hour per day. And maybe that's 2 hours, like twice a week with the BCBA like myself, and then twice a week with an SLP. Because at 2 to an hour of intervention, when it's done, by a master's level clinician, it's going to be, very packed with learning opportunities, rather than trying to train, a BI that's fresh out of high school and, just learning things on how to, keep a 2-year-old's attention for 2.5 hours, right? And it's not going to be fun or productive for anyone. So that's normally what I like to do till about 2.5, and then gradually fade in the intensity depending on what they need. If we can just move, half to preschool, but it's very based on just where I think they're going to benefit the most. So I'm definitely going to a more traditional ABA program, whether that's 15 hours, of intervention a month or a week, and doing that. But really looking at what the family needs and what the child needs.
And do you use a specific framework though, like with the NDBIs, or do you bounce around?
I bounce around a bit. Like I feel with everything that's out there, everything's got pros and cons to it. So I find the Denver model checklist is great for the really early learners. So their level 1, I find fantastic, because I find the VB map doesn't have those super early skills. So I really like that. For a lot of things, I pull a bit from the VB map as well for that age. And then, I've received training like a few years ago. I did the PEAK certification, and I love the PEAK, but it's actually kind of too advanced for, pre-kindergarten, I would say.
Sure. Yeah.
So I always keep referring back and like, how can I use this? Because I absolutely love the kind of the theory and the way it's set up. But so I would say largely Denver model, early start Denver model, and then mixed with VB map and mixed with just parent goals are the things that guide the programming the most.
Right on. Well, for listeners, if you're interested in learning more about the Early Start Denver model, check out episode 3 with Maria Sample, and she kind of fills you in all on that, which is cool. Yeah, because it just seems like it would mold really nicely into that, and I've been sort of on a bit of a tangent. I've been talking with kind of autistic folk, and ABA reformers, and they all tell me that the NDBIs are the closest thing to getting it right in their minds. So I think I think this approach is probably going to be acceptable by a lot of groups, which is really neat.
Well, and I think it's a lot more developmentally appropriate when we're working with such littles. When we're working with 2-year-olds, I don't think we've got anything better than NDBIs right now to work from. But I always look at, like, we got to be, still taking data and looking at, is the child learning, right? And definitely starting with least restrictive. But there's been kids that I've really tried to do more of an NDBI approach, but they do need a lot more mass trial and DTT and, very focused on, one skill and not learning it in, a generalized natural setting to begin with. But, I always try it there first. But if it's not being acquired that way, you can keep going with what do you need to do for the child to learn. Dorothy Lehrman, she does some really interesting research on pre-assessment. So looking at how does each child learn best? Do they learn best in a natural environment? Do they learn best doing random rotation of the targets? Do they learn best doing mass trial of a target and then generalizing? And like when you look at, okay, what's the end goal, is that they can do this in, a naturalized setting with, different people and different stimuli. And then you can do a few different targets in different ways. And what's the quickest way to get them to that end goal? And so doing those kind of pre-assessments before just starting intervention with the child, and just assuming that you're always going to put in 3 targets and you're always going to do this correction procedure, because actually each child, sometimes kids can learn better with 5 targets at a time. Sometimes doing 1 at a time and then putting them into a random rotation will actually get them to the end goal quicker. And some kids learn great in a natural setting. And that's, any kid that does, I would prefer that over table time anytime. But I think, you have to look at, is it working, and using the data to guide that.
Cool. Before we kind of wrap up, there was one area I totally meant to ask about maybe an hour ago, and I don't know if I'll just try to edit it in or not, but or we can just answer it here. I did a interview, and I don't know which one will come out first, but with Gabrielle Stigant. She does a lot of work with girls with autism, and I was wondering, sort of, from what she had told me, it's even harder to diagnose in girls autism. And so does this sort of early screening stuff, does it work with girls?
So that's
a better way to ask the question.
Incredible question. So I recently published a systematic literature review on what have been the earliest documented signs and screeners. And out of all the studies, I believe only one divided up by gender, maybe 2 studies. And so that was one of my recommendations, is that we're really looking at it as a whole rather than looking at what are the earliest signs for girls, what are the earliest signs for boys. The one that really did separate it, what they found is the signs were actually drastically different. So with eye contact, what was so interesting is girls that later went on to get a diagnosis of autism, when they were between 6 months and 18 months, they actually showed more eye contact than typically developing kids. And so girls with autism, it actually, there's a girl I follow on TikTok, Paige Lyle, she talks about, she gives more eye contact than is, say, typical, or just, more than you'd expect with ASD. And so this one study of infants found that, with girls, baby girls with that will go on to get a diagnosis of autism, their eye contact was actually far greater than typical development, which I thought was
wild,
fascinating. But also it's such a gap in the literature, the screeners, everything, is that we haven't divided this by biological sex of how symptoms are dividing. And it was super interesting why that hadn't happened, and why it was just, they've divided kids into, high risk, meaning they've got a sibling with autism already, and that's why they're tracking them, versus, low risk in that they don't already have a symptom with it. And so, but they're not dividing it up by genders. So I would say, no, the screeners have not been developed with just females in mind, and females are still likely to probably fall through the cracks unless their symptoms are presenting the way that boys' symptoms are presenting. But everything that we're starting to learn now about girls and autism is that the symptoms are different. They're masked different. They're presented different. The onset's different. And so I think a lot of research needs to be done on the difference in red flags and onset, of the different sexes, because I don't think it's been done.
So it's so interesting. It'd be interesting to know, like, if a 9 months old or 12 months old passes the screen because she has all these characteristics that you would normally probably see in a boy with autism. Down the road, would that person then be more likely to identify as like non-binary or transgender too, and sort of those sorts of pieces too? And just as far as like, is it a biological thing or is it a gender thing? Is it,
like the girls that I worked with in my study that, were screened positively and did have the red flags, like the screeners definitely did work, for them. So there definitely, I would say, are girls that are following, that the typical trajectory.
Yeah.
But I don't know how many we're missing that aren't following that trajectory, right? And it seems like a lot based on how much later girls are getting diagnosed than boys.
So I guess the one kind of final question about kind of your program is, okay, so I didn't, my kid didn't screen, say, didn't pass a screen, but I know there's a lot of autism in my family. I know there's a lot of other sort of risk factors there. Would it hurt to follow the program anyway?
No, not at all. Like, so that's what I think is amazing about it. And even just when you think about ABA in general, like, it's really just, you're not looking at, is a diagnosis there or not? You're looking at what should they be doing that they're not doing? And how can we teach that? And how do we fill in those gaps, right? And a lot of those skills, at one are such behavioral cusp skills that when they don't learn them, it's going to block them from developing the next set of skills and the next set of skills. And so, if your child's delayed for any reason, following the manual won't hurt at all. It's almost just like extra tutoring, right? And making sure that they're,
Well, I almost wonder, even if they weren't delayed at all, could it even be like there's no science behind this, so you can't really say this, but could it even be like, preventative in some way? Like, say they come into contact with some form of trauma later, maybe this would, mitigate a developmental, regression or something. Who knows, Okay, that's awesome. So what's next for you? I by the way, I plan to not release this until you've got all your stuff up.
Perfect.
So when folks listen to this, it'll all be available on Amy's website, which will be in the show notes. So you won't have to look for that, because that's a good indicator of when to release. I was trying to decide when to put it out, so that gives me a timeline. What's sort of next for you? Beyond that.
So on my website right now, under research, there is like an hour and a half note that I did do in Greece that kind of goes into all this research and stuff more in depth if people just want to learn more there. And then I'll have my manual just available on the site. And then hopefully the first few video lessons that are available for both clinicians and parents, so that if you do have concerns, one, how to even start to assess your concerns, going over the screeners there, and then breaking it down kind of week by week. So just weekly video lessons on there that they can watch and learn, and at least start to just disseminate some of this information. I don't know of really anyone else in the province working with kids this young. And so I feel I get often just word of mouth referrals. There's a few pediatricians that know that I do this work. And so when parents go to the pediatrician, those ones refer to me. And so it's a lot for me to take on. So I really need to build up some more capacity, more clinicians doing this, and even just have resources for parents for the kids that I can't see. One benefit though is because it's only, an hour a week per child, it does allow you to see a lot more kids, but having things more automated will only help that much more. And then they could always, go through those 12 lessons on their own, and then, bring myself or another BCBA on after that, right? And then moving from there. So we'll reduce their cost and kind of get them ahead and get them information right away.
You also do a little work like in a pediatrician clinic, don't you? Or you were? Or
No.
didn't you say that? Didn't you say you were doing something with a pediatrician?
So I.
Well, maybe not. Maybe that was someone else. Okay, never mind.
Yeah.
I take it back. Yeah, I was talking to someone who said they were working part-time in a doctor's office.
I thought Michelle Shavak was at one point, but I don't know.
Oh, maybe it was Michelle.
Yeah,
maybe it was. Maybe that's who it was. You're right. Got my T's uncrossed. Well, that's awesome. It's really good stuff, and I hope folks listening to this will kind of get a hold of you and try to sort of, because it's going to be a lot of BCBAs. This will be a CEU, and I hope folks will want to expand their practice and learn this piece. I think it'll be really good. And I imagine it's a lot of fun working with the super little ones.
It's so fun. I've got a 6-month-old on my caseload right now, and it's so much fun.
And I could even see this transferring, on some level, maybe over to like the whole infant development folks, right? And
yeah,
I don't know if that's something you've...
So I often work hand in hand. So a lot of times there are people that also refer me because their cases are a bit limited or their time.
Right.
So they've given me quite a lot of referrals. But I know,
Gotcha.
I think UBC was given a big grant to do some research about how to create a model where they're using infant development to kind of roll out some of this training. It was a bit older. Cool. I think it was 2 years and up. But it is definitely, infrastructure that's in place that we can use a bit more.
Well, thanks so much for being on the podcast with me. So such cool stuff, and such, I love that it's such kind of pioneering work in the province, and hopefully we can really build capacity with a bunch of folks through this. So just really neat stuff. Thanks a lot.
Awesome, Ben. Thanks for having me.